Welcome back to the channel, dear friends, and in today's video I'm going to demonstrate a direct chop. In this particular case, you can see that there is a wick of a merisal sponge in the inferior fornix, which is kept there to prevent pooling of any kind of fluid on the ocular surface. So this gives you a clue that this was a deep-seated eye. This video is going to be a single take, unedited video, and by now the two side port incisions have been made and we're going ahead with staining of the anterior capsule. The most commonly used viscoelastic substance in the Indian subcontinent is 2% HPMC, and I'm going to use 2% HPMC to replace the dye and the aqueous in the anterior chamber. HPMC, being a dispersive viscoelastic, has very good coating abilities. So not only do I use it to coat the corneal endothelium, but I also use it to coat the anterior corneal surface, which enhances visualization and gives a slightly magnified view. I'm now proceeding with a superonasal 2.8 mm clear corneal incision. So after raising a capsular flap with a 26 gauge bent cystotome, we go ahead and complete the capsular axis with a Utrada forceps. So we've achieved a continuous curvilinear capsular axis, and I believe the diameter to be approximately 5.5 millimeters, and they should overlap over the optic of the IOL pretty well. Hydrodissection is carried out routinely, and the fluid wave is brought forward by compressing the nucleus in the center, and I do a multi-quadrant hydrodissection, and the nucleus is rotated with the same hydro cannula. It's a good idea to coat the endothelium again before entering the anterior chamber with your phaco tip and delivering ultrasound energy into the anterior chamber. So I'm using the phaco tip in a continuous irrigation mode. As you just saw, I compressed on the foot pedal outside the eye and let a gush of fluid come out of the phaco tip before entering into the anterior chamber. And after emulsifying some loose cortical matter, I'm impaling the nucleus with my phaco tip in a bevel down position, and I have managed to get the first chop. In this particular case, I'm using a vacuum of 450 millimeters of mercury with an aspiration flow rate of 45 cc per minute and about 50% phaco power, which is pulsed at 40 Hz. So as you can see, the direct chop is going on very nicely. I'm impaling the nucleus in a deeper plane, lifting and tilting the pole up slightly with my phaco tip and bringing the chopper in from the periphery towards the center before doing a lateral separation and hence completing the direct chop, in this particular instance a horizontal chop. I'm using the Oertli Catorix Easy Phaco machine by Oertli, Switzerland, and the chopper in my left hand is the Agarwal chopper made by Epsilon in India. I have no financial interest in the products of either companies. So after fragmenting the nucleus into various small pieces, I remove the sharp chopper from out of the anterior chamber and use a Y manipulator to toss the smaller fragments towards the phaco handpiece. If the capsular axis is of an adequate size, bringing out these smaller fragments out of the capsular bag towards the phaco tip is not very difficult. A smaller capsular rhexis would require more manipulation. The idea is to always stay in the central safe zone with the sharp phaco tip and to keep the Y manipulator behind the nuclear fragments in case the phaco tip traverses through the nuclear material, and to protect the posterior capsule from being punctured inadvertently by the phaco tip. Middle-aged obese patients usually have some component of sleep apnea because they have a heavy chest and bust, and as you can see that the eyeball is oscillating in a vertical manner and reflecting every breath that the patient is taking. So just when you think that you've had a near perfect case, in this particular instance you can see that my irrigation cannula is not going in through the side port on the right side. So maybe the side port incision wasn't wide enough to allow this irrigation cannula to go in. Nevertheless, this is a very small deterrent in the surgery, and I switch hands and bring in the irrigation cannula from the left side port, and with a lance blade I widen the right hand side port. As I proceed with the cortical aspiration with the bimanual irrigation aspiration cannulae, I notice that my right hand side port is more leaky than usual, and this was really expected if I try to widen the side port at this juncture in the surgery, which has led to an unstable side port and has caused chamber instability. So in this particular instance, it's advisable that we do not compress the foot pedal too much and use a very controlled vacuum. My preferred technique for IOL implantation is the hydro-IOL implantation, wherein I use an irrigation cannula to continuously keep the capsular bag inflated with BSS and to gradually inject the IOL with my other hand under this continuous flow of BSS into the anterior chamber. Repositioning the IOL into the capsular bag is fairly easy when you're doing a hydro-IOL injection. It does not require too many maneuvers, and it's easily possible using the IA cannula itself. So the capsular overlap over the optic seems to be adequate, and now I'm going ahead with the side port hydration, and this concludes the case, my friends. This was a swift direct chop with a little imperfections. If you have any questions, I'll take them in the comment section below. I'll see you in the next video. Thanks for watching.